I'm Katrina Watt. I'm TSA's telehealth nurse. Before we start the presentation, I just want to let everyone know that we'll be muting people during the call to ensure the best quality of audio for the presentation. We do, however, encourage your participation tonight. So if you do want to answer a question or make a comment, please put your hand up digitally, and you can take yourself off mute by pressing the space bar, or you can type a question in the chat. So we are going to be recording tonight's presentation, as I've said. So to tonight's presentation, skin issues affect 4 out of 5 people living with TSC, and as most of you will know, because of their high visibility, these issues can be very distressing. So our presenter tonight is dermatologist, Associate Professor Deshan Sebaratnam. Associate Professor Deshan is a staff specialist at Liverpool Hospital. He has a strong interest in research, having published his work in international medical journals and presented at conferences around the world. He is an academic at the University of New South Wales and the University of Sydney. Deshan was also the winner of the 2023 TSA Elizabeth Pinkerton Memorial Award. And tonight he's going to tell us about the symptoms, treatment, and management of TSC-related skin issues. Thank you so much, Deshan, for joining us this afternoon. Oh, this evening, rather. I will hand over to you now.
Yeah, great. Thank you very much for that introduction. So as mentioned, I'm a dermatologist. I'm a skin specialist. I see kids and adults as well. And so today I'm going to be talking about skin changes in tuberous sclerosis. So a little bit about what these changes look like, and then a little bit about treatment options as well. And then we'll open it up to questions at the end. So as mentioned, with tuberous sclerosis, there are lots of skin changes that can be part of this syndrome. So we have a large audience today, and I know this will be sort of basic knowledge for a lot of people. But I guess just to make it as broad interest as possible. So with tuberous sclerosis, there's a spectrum. Some people might have a lot of the changes that you see in tuberous sclerosis, and some people might not have very much at all. And even within a family, it can vary from person to person, even if they both have the same mutation in their genes. And so in terms of skin changes that you can see in tuberous sclerosis, often they're the first things that a patient might present with, or that might point a doctor towards a diagnosis of tuberous sclerosis. So this is the criteria for tuberous sclerosis. And you can see that out of all of these, quite a few of these are actually skin changes in terms of the clinical criteria. Some people might have none of these changes. Some patients might have all of these changes. But skin certainly plays an important role in terms of diagnosis, because sometimes the skin changes can be the first clue to the diagnosis. But also, I think it's important because the skin is the organ that you sort of face the rest of the world with. And it's not always easy living with a visual difference. And now we do have treatments that can help with some of these when they're cosmetically bothersome. So we'll start off first of all with angiofibromas. So with these, they are little bumps, and they normally present towards not when kids are first born, but around primary school age. And they'll start off with these hard little bumps around the central face. So a common story is that people can think, when patients first present, doctors might think that this might be an early presentation of acne, for example. But I guess separating these bumps from pimples are some things which come and go. Whereas once these bumps are there, they'll be static and they'll be stubborn. And so with angiofibromas, the name tells you a little bit about them. So they're made up of two components: angio, meaning blood vessels, and fibromas, because they're little lumps of collagen. And so that's the main thing that you get with tuberous sclerosis. You get lots of little lumps or scars within your body. And so on the skin, these little lumps can be the angiofibromas, or if they're bigger, lump of collagen. But then you also get other kinds of lumps in your lungs, in your brain, in your kidneys potentially. And that's the trouble with tuberous sclerosis. So this is one of the most common presentations. This is another common presentation, and these are commonly known as Ashley's macules. So now they've sort of shifted away from that, and they're calling them hypomelanotic or light-skinned macules, meaning a flat area on the skin. This is sort of a classic example because it's round on one end and pointy at the other, which is what an ash leaf is meant to look like. So this can also be one of the first signs of tuberous sclerosis. This is another one. So these are what used to be called, fibrous cephalic plaques, but these are very similar actually to Sjogren patches. They're all sort of synonyms for the same thing, which is where you get a deposit or a lump of collagen within the skin. It's just in a different location. In terms of other changes that you can see on your skin, so we call these periungual fibromas or lumps of collagen around the beds of the nail. You can get similar little lumps on your gums, so gingival fibromas. You can see pitting within the teeth. This is another example of angiofibromas. And on this photograph here, you can see a collagenoma with that sort of honeycomb pattern to the skin. And then they talk about guttate hypermelanosis, or like confetti-like depigmentation, where you can see it's like someone sprinkled confetti, and wherever the confetti's landed, you're left with these little white spots. And these are all the skin changes that you can see in tuberous sclerosis. So in terms of, sorry, one more thing. So if you see a dermatologist, they might get out something called a dermatoscope. The main reason doctors use dermatoscopes is for assessing skin cancers, but it can also give us some extra clues. So with the dermatoscope here, you can see a change called the red comet sign. So you can see here periungual fibroma, so a little lump of collagen around the nail, and it looks like it's shooting out a red comet when you look at it under the magnifier. So that's another sign. It's not part of the criteria, but it's something that you can see in tuberous sclerosis. So most of these all of these changes that I've spoken about are completely harmless. They're benign, but they can have a big impact on your quality of life. And so the management of all of this has changed rapidly in the last decade or so with sirolimus, which is also known as rapamycin. So sirolimus was actually an old-fashioned antibiotic that they found on East Island, but they realized it had a few other properties with it as well. It has immunosuppressing actions. It has actions to stop blood vessels reforming, and it also inhibits the mTOR pathway, which is one of the pathways that goes funny in tuberous sclerosis. It dampens down that pathway, and in doing so, it can be a treatment for some of the skin changes we see. So in terms of sirolimus, it comes in different strengths, 0.1 to 1% ointment. Ironically, there's a bit of a suggestion that sometimes the weaker the ointment, it might seem to work a little bit better in patients. The prices vary a lot. If you have a look at the Tuberous Sclerosis Australia website, it's actually really helpful because in each state, it goes through a few different pharmacies which do it at a low cost. And prices can vary very widely from location to location. In terms of the treatment, it's pretty safe. There's very few side effects. So one of them is pimples. It can slow down wound healing. So if patients are, for example, going to have laser or surgery, I'll normally get them to stop the treatment for a little while. With any medicine, you can get an allergy to it or you can be allergic to it. And then if you're applying it to large amounts of the body, then a small amount of it can be absorbed, and we can detect that in the bloodstream as well. It's not normally of any real significance, but we know that if you're, for example, taking tablets sirolimus, then your side effects with some of these things. There are other side effects that I didn't talk about, like mouth ulcers or changes to cholesterol or affecting your liver function, things like that, which I guess you need to be mindful of. And the other thing is you don't just need to apply, or you don't just have to apply the sirolimus as a cream. If you're taking it in a tablet form, it will get to your skin in that way as well. So sirolimus was the sort of OG, and now we've got everolimus, and there's other mTOR inhibitors. But in terms of creams or ointments, which is sort of mostly what I do as a dermatologist, sirolimus or rapamycin is its other name, is the main one. So this is from one of the original studies that was published out of Perth. And you can see with this little chap an improvement in terms of his facial angiofibromas, and this is just with the sirolimus. So this is the website that I was talking about. So if you just look, it's on the TSA website. If you look up availability of topical sirolimus, it goes through different pharmacies and different costs and so forth. So that's one part to management. And with most of the changes of tuberous sclerosis, you can see an improvement with the sirolimus. But it's not 100% curative. It can soften some of the changes, but it can never, it's very rare for it to eliminate them completely. It's not a magic wand. And for that, then there's other things that we can think about. So one of them is vascular laser. And with vascular laser, it targets anything that's the color red. So there's a few different types of vascular laser. This is the most common one, the pulsed dye laser. You might know it as a popular company that manufactures it is Candela, Candela V-beam. And that's what they have in most of the public hospitals, at least in the kids' hospitals. There's another one called the ND-YAG laser, KTP. And then there's also something called IPL. So that one is not strictly speaking a laser. A laser normally only emits one wavelength of light. IPL is sort of more of a beauty treatment because it's helpful for evening out reds and browns at the same time. Strictly speaking, that one isn't available through Medicare, but it's something that can be helpful. And so what the laser does is it seeks out and destroys anything that's the color red, but it leaves the surface of the skin intact. So hopefully this video works. So you can see that the top layer of the skin is left intact, but the blood vessels or anything red underneath ruptures. And that's what we want. We want to get rid of those excess blood vessels that are contributing to the redness of angiofibromas. So this is a video of a little boy getting something else treated, but
ready, set. That's it.
Yay!
So you can see it's not too horrendous getting the actual treatment done. It's like getting flicked in the face. Depending on how old the kid is and how many, the surface area. We can do it even in primary school aged kids. Normally we put numbing cream on beforehand. In a big area, what you'll find is that you get lots of bruising and redness afterwards. So even though the top layer of the skin is left intact, it's like sort of being punched in the face. Lots of bruising, lots of redness. So you just need to plan around your work and social commitments. Because we're not damaging the overlying skin, as you walk out of the doctor's room, you can put tinted sunscreen or makeup, things like that, but it'll still be obvious that you've had something done after the procedure. So bruising is something that we expect to happen. With the laser beam, it comes out in a circle, and it's hard to get it to, or it's impossible to get it to overlap perfectly. So sometimes you can get a little bit of a pattern where it sort of looks like buckshots or a shotgun, where you can get a contrast between the treated and untreated areas. So we call that sort of honeycombing, but that normally evens after multiple treatments. And normally you do need multiple treatments. With the angiofibromas, they usually come back on the face. And so you sort of need a maintenance treatment from time to time. So the way I explain it to patients, it's a bit like pulling out the weeds. It's not like you can just pull out the weeds from your lawn once and that's it. Eventually they'll start to grow back. Using sirolimus can be helpful because it can minimize or the need for, it can sort of extend the duration between treatments. Normally, I like patients to stop the sirolimus about a week before they get the treatment because it can impair your wound healing and increase your risk of things like burns. So you can get burnt with this laser. Scarring is possible. Infection is possible. It's rare, but it's something that we know can happen. And that's true of any time you introduce any kind of destructive energy to the skin. So someone asked a good question. Could you use this for periungual fibromas? Normally with periangle fibromas, the issue isn't the redness, it's the texture difference. It's the fact that you've got a little bump on it. So not so helpful. We'll talk about some other treatments for that. Another good question was, can you use this on darker skin tones? Yes, you can. You have to be a little bit more careful. So with my skin or with anyone with darker skin, there's a layer of melanin on top of the blood vessels. And what can happen is the laser destroys anything that's the color red, but you have a little bit of red in brown. So what can happen is that laser energy can be absorbed by the top layer of the skin and lead to things like blisters and burns. So the whiter your skin is, the safer this procedure is. But you can still do it in darker skin safely. You just normally have to be a little bit more conservative. With darker skin patients, I'll often encourage them to sort of do it towards the end of winter. So let's say August or September, because normally that's when everyone's skin is at its lightest. Sirolimus can help. There's other vitamin A type medications which can be helpful as well to help minimize the chance of those burns. But that's an excellent question. With most forms of laser, the darker your skin is, the more dangerous it is. And that might be an example where you might opt, for example, for, if I can go back, this laser, so the 1064 Nd:YAG laser, that one's meant to be a little bit more color blind because that targets, well, I guess, yeah, I don't need to go into the physics of it, but the longer the wavelength, so the bigger this number, in theory, the safer it will be for darker skin, but it's not a hard and fast rule. So we'll skip forward a little bit. As I was saying with periangle angiofibromas, for example, the problem is that you have a little bump sticking out of the skin. So this won't help at all with any texture difference. This only helps with color. So in contrast, when you do have texture problems, for that you need something called an ablative laser. So that's a destructive laser. It's sort of what you think about when you watch James Bond movies or things like that. This one targets water and it blows up the water. So it's an explosive type of device. So there's two common ones. There's erbium-YAG. You just have to be careful because there's a few different types of erbium laser out there. Erbium-YAG is the important one, also the relevant one, and then also a carbon dioxide laser. So with this one, erbium is normally a little bit safer for lighter skin, but again, it just depends. So if you're, erbium is safer for darker skin, so that's what you'd want to use in a darker skin patient. Carbon dioxide is a little bit more aggressive. And these are both available either as a continuous beam where you're forming like a laser beam or what we call fractionated lasers. And I'll go through some videos explaining the difference between them. Normally, what most doctors will have available is the fractionated lasers. The reason being is that they're used for sort of anti-aging and acne scarring. If you're going to spend hundreds of thousands of dollars on a laser, you want to be able to treat as many patients as possible. With the older fashioned ones, which are for a single laser beam, they're really only helpful for things like, some people treat moles with it or age spots, or obviously with conditions like tuberous sclerosis. They'll still be a little bit helpful to fractionated lasers, but the fully ablative lasers are slightly better. And then there's still good old-fashioned treatments like diathermy, which is, I guess, cautery, or essentially we use a little wire and that electrocutes the top of the spots. That's, again, a great treatment for darker skin patients. Not every doctor will, have access to lasers. But most dermatology departments or most dermatologists will have access to diathermy. So that's still an excellent treatment option. It's old, people think that lasers are, the be all and end all, but they're not necessarily safer or better. I still use diathermy a lot. So this is a fully ablative erbium-YAG laser. And what it does is for each little spot, it planes it down until you're flush with the skin. So we'll watch some videos. Yep. So if you sort of want to imagine that each angiofibroma is almost like a little potato or an iceberg. So you've got the bit above the surface, and then it's got a root underneath. So to remove it completely, you need to cut it out, but then you're going to be leaving the patient with lots and lots of surgical scars. So the goal is to sort of plane it down so it's flush with the skin or even a little bit underneath, so you have a small dell, and then hopefully that sort of suppresses that angiofibroma. So it's a bit of a pain. It's a painful procedure, and you can imagine if you've got hundreds of angiofibromas, then it takes a long time, and treating each one can be painful. You can do it under a general anesthetic, so this patient is on under a general anesthetic, or if it's only a few, you can put in local anesthetic, so that's with the needle, so the patient isn't knocked out, and go through treatment that way. So this is an example of a fully ablative erbium YAG laser, and this is a patient of South Asian heritage. So just because you have darker skin, it doesn't mean that you can't receive laser treatment. So what I also do afterwards is to then treat the area with a fractionated laser. So with this, what I want to do is to sort of blend between the treated and the untreated areas. So it's a gentler treatment option, but it can just help giving you a slightly nicer cosmetic outcome. So with this one, rather than a single laser beam, what you get is a grid pattern throughout the skin. So someone asked, is this something suitable with kids? So it depends, I suppose. Certainly you could do this procedure in a child. I think most kids would need to get it done under a general anesthetic. And then it's sort of this tricky thing where logistically it becomes a little bit of a challenge, because to do it on a kid, I mean, pretty much you need a general anesthetic. Most, at least in New South Wales, I don't know about other states, there's nowhere that I know of that has general anesthetic facilities for a child who also has the ablative laser. Because I guess from a business perspective, you know, the public hospitals and stuff like that, this is not something where they're going to be using it a lot outside of conditions like tuberous sclerosis. Some hospitals, for example, if they do lots of burns, they might have it. It depends on the kid though. Like if you know there's not that many lesions and it's a really brave kid who's maybe in the later stages of primary school, with things like a Valium, a numbing cream, you potentially could get it done. It varies a lot from kid to kid, but generally I'd say it's probably more reserved for adults. So even at the place where I'm doing this now, it's called the Skin Hospital. You know, it's an accredited day hospital, but they won't treat anyone under 15. And I don't know any pediatric hospital that's set up for peds that has the laser. So it's tricky to find the intersection of that Venn diagram. But going back to what I was saying with the grid marks, so then I sort of use this to blend the area. So instead of being a single beam, what you'll see is that it's lots of dots in a grid. So I'm only treating one fraction of the area, hence the name a fractionated laser. Okay, so if you have questions, feel free to type them in. It's much easier because otherwise I'll forget them at the end. Okay, so then someone asked about angiofibromas on the toes. So again, if you use this sort of toe as an example, you can see that, yes, it's a little bit pinker compared to the surrounding skin. But even if you were to get rid of the pinkness, there's still going to be a texture difference. So the texture difference is the most conspicuous thing. And so for this, you could either use diathermy, but I'll show you how you would treat this with a laser, an ablative laser. How are you feeling? Ignore my voice. So you can see you just go slice by slice. So that's, you know, sort of 10 to 20 microns, so 1/100 of a millimeter. down until it's sort of in perfectly aligned or as close to perfectly aligned with the skin as possible. So someone asked a good question. Is it going to produce long-lasting effects? I guess long-lasting is subjective. It's not permanent by any means. What normally happens is the spots tend to come back. It's very difficult to predict how long that will be. So for some people, they get it done as a once-off, and then the spots come back, but they're only tiny, tiny little bumps, and it's never really much of a concern. For other patients who are less lucky, it comes back pretty quickly, and it's like they never had the treatment done. I still don't have a good way of predicting who is who. On balance, I'd like to say that, with each treatment, it comes back a little bit better. And I think part of that is you actually get a little bit of scarring, which sort of keeps a cap on the growth. But that's how you do an ablative laser. So the treatment with the diathermy works just as well. I would say it's perhaps a little bit less precise. So with the laser, it's literally going, like I said, that's 100th of a millimeter. So you can be very, very precise with that, which is sort of why I like it. It's also better over like curved surfaces. If you have a very flat surface, then diathermy or the laser, it doesn't make too much of a difference. Now, someone asked a good question. Are these on the MBS? And the answer is yes. So the red laser is available if you can see the angiofibromas from 3 meters away. And you just need to have a dermatology setup where they can take photos, and you get 4 treatment sessions in a year. So with that, it's not 100% covered. So you get about $140 back from Medicare. If you have lots of different doctor's appointments and you reach the Medicare threshold, I think you get an extra $100 or so back. But it can be expensive. Anyone who is in New South Wales, you can get it for free at Liverpool Hospital with me. But yes, obviously, logistically, that's not necessarily available. And I think most doctors would, give a different rate for someone who has, for example, angiofibromas compared to someone who's getting laser treatments for a beauty type reason or a cosmetic type reason. And then for the ablative laser, yes, there is an item number for this as well. Now, I'm not an expert when it comes to private health insurance and stuff. The red laser isn't normally covered by your private health insurance. This item number, 30190, is normally covered by your private health insurance. And it's considered medical rather than cosmetic, although now with all the private health insurance companies sort of being a little bit tighter, I had one patient who actually had it rejected because it was considered cosmetic. I can't remember which health insurance company it was, but yep. And so someone asked whether you could follow on the treatment with sirolimus, and that's what I normally recommend to patients. So what I'll normally say is do the sirolimus, see how much improvement you can get with the cream because it's safe and it's less downtime and probably cheaper, I suppose. If you're not happy with that degree of improvement, then you can do the laser. And then once everything's healed up, I like them to continue on sirolimus because I want them to need treatments as infrequently as possible. Having said all of this, a lot of the stuff with sirolimus is still relatively new. That paper I was talking about from Anne Halbert's group in Perth, that was only about a decade or so ago. A lot of this is sort of not based, on hundreds and thousands of patients where we've had head-to-head studies. A little bit of it is sort of, trial and error or talking to other colleagues. And so everything I'm saying might be, out of date in a year's time if someone else does a study. And then another question is it better to do it sooner rather than later? My feeling is yes. With anything, right? Like pulling out weeds in the garden. If you can pull them out when they're little, then the roots don't go as deep. And so I mean, yeah, that's sort of my thought. And again, with the small angiofibromas, for example, they will often respond to topical sirolimus, but once they get more established, it's not going to go, penetrate deep enough. Or if there's enough of a little ball of collagen, you're not going to be able to sort of dissolve that. So certainly with topicals, I think, or with anything, I suppose, I think it's better to sort of start earlier. So that's actually the end of the formal bit of the talk. So in terms of helpful resources, as I said, TSA's got a really helpful resource in terms of topical sirolimus in your state. I've got an Instagram, which is just dr.deshan. It's not just about tuberous sclerosis, but there's some more videos if you want to see laser treatment of tuberous sclerosis, but also other types of laser type treatments. And then in terms of referrals, so you can refer to see me at Liverpool Hospital. Your doctor just has to specify that it's for tuberous sclerosis and for vascular laser. Most hospitals are sort of a bit territorial in terms of not seeing patients within the catchment area. So you just have to be specific because most other public hospitals don't have this. Although Royal Prince Alfred Hospital in Sydney is starting as well. And so then for the periungual fibromas, you know, if 0.1% isn't working, you can maybe go up to 1%. But I guess, again, once it's established, once you have that little ball of collagen and blood vessels, the cream is unlikely to make it go away completely. You're probably going to have to need something a little bit more surgical. So sorry, I don't know enough about the ins and outs of the different states. I only know about my home state, which is New South Wales. So in terms of, I don't know if anyone's done a good head-to-head in terms of topical versus sirolimus. That's an excellent question and one that I've always often thought about as well. Because sometimes I'll see patients who might, for example, be on the tablet sirolimus and they still have, you know, bad skin disease. And I've often wondered, you know, about, oh, if you put topicals on top of that, might you get a bit of extra improvement? I don't think anyone's done a head-to-head or looked at that specific question, so I can't give you a good scientifically based answer. Ablative laser is not available at Randwick. I'm fairly sure vascular laser is. I don't know who can access it and who doesn't. I think it's more for vascular birthmarks, but I mean, at Westmead Kids, for example, I'm pretty sure that you know, as long as it meets the Medicare criteria, it's available. At Liverpool Hospital, we see kids and we see adults as well. Yes, but I'm not sure the ins and outs of each specific one. Yep, if anyone has any questions, feel free to type. So I don't think there's anything specific in terms of genital involvement. Any of the things that we mentioned before can still happen in the genitals. So collagenomas or hypopigmentation. So the other thing to mention is sirolimus can help with those collagen growths. The Sjogren patches or the fibrocephalic plaques. It can also help with the hypopigmented, so the white ash leaf macules as well. But the broad principles would still apply to the genitals. Yes, so it can be tricky to tell the, oh dear, I lost it. It can be tricky to tell the difference between rashes and angiofibromas. I guess the angiofibromas will always be there. They're not going to go away by themselves. But with other common, you know, there's lots of different things that can still happen to kids' faces, like slapped cheek or sunburns or pimples. Yes. So if you're not sure, your GP is not sure, you can always see a dermatologist. But I guess even if it was parvovirus, if he's normally happy and healthy and you're not around anyone who's pregnant, and he's never had any issues with his blood counts, parvovirus should settle itself down. Yeah, so unfortunately, it is very expensive. Yes. I'm just reading. I'm sorry, I'm just trying to scroll through. Yep, so the topical sirolimus can be helpful for the white skin patches as well. So normally with the facial angiofibromas, they'll present sort of by primary school age, so a little bit earlier than you'd expect someone to be getting pimples, for example. So sort of early, mid primary school age. I mean, I think if you got into your 20s or your 30s and you didn't have any angiofibromas, it would be unlikely. But one of my patients had the subtlest, tiniest little bumps, never even paid any attention, and then just had one periungual fibroma, and then as part of sort of some blood work she was getting for another reason, ended up going down the TS pathway, and then that's what it ended up being. So it varies a lot from person to person. So again, I guess it's tricky. I don't want to give anyone the wrong advice. So I guess maybe no specific. I guess it's hard for me to be super helpful without actually taking a history and examining the patient and stuff like that. So yep, they can often get worse as you get older if it's presenting, in early primary school age. With the sirolimus ointment, yep, Woods Pharmacy is pretty good. But if you have a look at the TSA website, there's other ones, and it's funny sometimes. Even if you counter in the cost of postage, sometimes it is cheaper to get it interstate depending on where you are. So for topical sirolimus, we have, so even oral sirolimus, some patients are on it long term. It's not just used for things like tuberous sclerosis. We also use it in transplant patients who need to be on it for their, to stop their organ transplant getting rejected. And then if you are on systemic or oral sirolimus, normally whoever's prescribing it will be doing blood test monitoring. For topical sirolimus, it's only a tiny, tiny amount that gets absorbed into your bloodstream. So you don't need to get it checked. So for most medicines, doctors or dermatologists like ointments compared to creams. In an ointment, normally drugs dissolve a little bit better and they get delivered to the skin a little bit better. It's not a hard and fast rule. Creams are nicer because they sort of melt into the skin and they're easier to apply. But in general, we go for the ointment over a cream. So that would be, general advice for things like eczema and stuff like that as well. So you don't need to really apply gloves when you're, applying the ointment. If you're applying it to yourself, just wash your hands afterwards. Or if you're applying it to someone else, just wash your hands afterwards. So you don't need to be a specialist to prescribe the ointment, but not every GP will be familiar with it. It's a very niche thing, and like you never want a doctor to do something that they don't feel comfortable with, right? And so if they won't, I mean, most dermatologists would, or if you often bring in the tub or the tube or the letters from your last doctor, you can then the doctors might feel a bit more comfortable. There's also a website, I should have included it here. It's called Virtual Dermatology. So with it, I don't work there, but I know a lot of dermatologists who do. And so it's sort of a telehealth type setup. And so, all the dermatologists who work there are great. And for people who live in the country or aren't near a major hospital or don't have a dermatologist, near them, I mean, any of them would prescribe the topical sirolimus. So yeah, it's called Virtual Dermatology. I think it must be .com.au. It's one of the pinned posts I have on my Instagram. So yeah, that was set up by one of my colleagues. But yeah, I mean, you don't need to be a specialist, certainly. And then Yep. So a few different good questions about logistics. So yes, some hospitals, it actually varies from hospital to hospital in terms of if they stock it or not. So if you're a kids hospital, so sirolimus isn't just used for, as I said, um, angiofibromas and changes of TS. I use it a lot for other types of birthmarks as well. So most of the kids hospitals will have it. For the adults hospitals, it's unusual for them to keep it in stock. But you're right, often that is the cheaper one. Oh, thank you for whoever posted that one. But then, yeah, normally need to be known to the dermatology department. So I think that's about it. We finished a little bit early, which is not a bad thing.
Yeah, perfect. So thank you very much. Please, everyone join me in thanking Deshan so much for his time and expertise. And thank you so much to everyone who's joined us this evening. So we'll be sending out a very short questionnaire tomorrow asking for some feedback. If you'd like to let us know your thoughts, it can help us guide and hopefully have more of these really informative sessions. And so thank you very much, Deshan. We really appreciate your input and all your expertise in talking to us tonight. Thank you.
No worries. Bye.
Thanks so much. Have a wonderful evening.
Thank you.